You can see that, right?
Yes, great.
Okay. So thank you very much for the invitation. And so the next 30 minutes or so, I'm going to just complete these objectives, which you can see on the screen. So first of all, I will be speaking about as to how do we choose treatments for our patients. And number two, I'm going to just go through some evidence for newer anti-diabetic medications, and these are based on the cardiovascular outcome trials. Then I'll also discuss what are the limitations on the use of these medications which have got evidence-based data, and how these drugs are also being misused in day-to-day prescription. And finally, I will discuss very briefly as to how we can improve our prescription writing for these patients. So the question is, how do we choose the treatments and how do we prescribe medicines? Now, majority of the physicians would agree with me that we prescribe medicines because we have been trained to practice evidence-based medicines. So primarily, majority of the physicians will actually go that route. Will choose the medicines that are evidence-based, and these evidence-based medicines, they do provide guidelines to clinicians, to physicians, and with these guidelines, we are directed as to how we choose and how we prescribe. There are some doctors, some physicians who will use their personal experience, and some of them will also use their gut feeling. But a very few will be hunting in the darkness. They will give and use anything they feel that will hit the target, anything they feel that will help the patient and help to cure the disease or at least allay the sufferings of the patient. Now, we must not forget that it is very important to keep in mind the patient preference. So that part of the discussion is to be made with the patient as to what the patient prefers, what type of medicine the patient prefers. And at the same time, the cost is an issue, and affordability should be taken into consideration when we prescribe medications to our patients. Now, when I say evidence-based medicines, now as you know in cardiology, there are a number of medicines that are evidence-based, and they have been being used for a number of years now. As you can see on the screen here, the antiplatelet drugs, clopidogrel, ticagrelor, they have got good evidence and they are being used for a lot of number of years, particularly for the atherosclerotic coronary artery disease and the patients in particular who are undergoing stent. Statins, there's no doubt there are loads and loads of evidence base that statins work. And despite there's a lot of information on the media and seen by the local general population and the patients that the statins can do harm. They are the drugs that may lead to diabetes and so on. There are lots and lots of propaganda against statins. But the fact is that statins do work, and there's a lot of data in favor of statin. Likewise, for the beta blocker, ACE inhibitors, mineralocorticoid, agonist, antagonist, then there are newer drugs like ARNI, which is angiotensin receptor blocker, neprilysin inhibitor, valsartan sacubitril. Some of you may know who are practicing cardiology. This is a game changer in cardiology, and in particular, patients of heart failure. This is a drug that has found its place right up on the pathway or the guidelines for the heart failure patients. And more recently, we are now focusing in cardiology on the anti-diabetic drugs. Now, this is a very interesting time when we are using, as cardiologists, anti-diabetic drugs. We never thought that we'll reach a platform where diabetologists, the nephrologist, the cardiologist, physician, they will all meet together and will be prescribing a drug that was entirely being used by the diabetologist. But I'll just go through some research, some trials that are based on these GLP-1 agonists and SGLT2 inhibitors. And the idea will not be to go into the depth of these trials, but I'll just show the evidence that these are the medicines that do really work. And we as physicians should be ideally using these medicines into practice. Now, there are also some misuse of medication prescription. And when I'm talking about the medication prescription, I'm not talking about a lot of medicines here. I'm primarily focusing on the newer anti-diabetic drugs. And these are the GLP-1 agonists. and the SGLT2 inhibitors. So some of you may know that these are the two anti-diabetic drugs. They are fairly new in the market, and they are being used for a lot of benefit, not only for the glycemic control reduction of HbA1c, but for the good cardiovascular outcome. And I'll show you some data as to how these drugs are very effective in reducing cardiovascular mortality, cardiovascular death, and so on. Now, these drugs, they do have some contraindications. They do have some limitations, which I've listed here. Severe renal impairment is one of them. For both of them, GLP-1 agonist and SGLT2 inhibitors, if the patient has got severe renal impairment, then this drug should be not used at all, or if they are used, they should be used very, very carefully. It should not be used in patients who are already dehydrated, in particular the SGLT2 inhibitors, because they work like a diuretics. So essentially, these drugs, for people who do not know what SGLT2 inhibitors are, and these are the drugs that help to filter out the glucose through your urine, and there's loss of at least 80 to 100 grams of urine sugar in your urine per day. 80 to 100 grams of sugar is lost. So it should not be given to those patients who are dehydrated, or particularly the elderly patients who are on a lot of polypharmacy, who are on high antihypertensive drugs and so on. And if the patients have got current UTI, and if the patients have got pancreatic disease, or there's high risk of decay, then obviously these medicines should be chosen very, very carefully. These drugs should not be used. Some of the physicians, they use these medicines as off-label in patients of type 1 diabetes. But mind you, the FDA has still not approved the usage of these medicines in type 1 diabetes mellitus. And it should also be avoided because both the medicines, they cause significant weight loss. Therefore, these medicines should also be avoided in patients who have got a very low body mass index. And because they cause weight loss, particularly the GLP-1 agonists, they should certainly not be used for weight loss alone. Now, this drug has become quite popular amongst people who are obese, and they resort to using this GLP-1 agonist as a shortcut of reducing weight. And so this is being used, again, against any FDA approval in patients who are not diabetic and they just want to lose weight. So in a way, these drugs are being actually misused. So what are the reasons for poor usage and of these newer anti-diabetic medications? So some of them are listed here again. Lack of awareness of current guidelines based on evidence of cardiovascular and renal outcomes from trials. Sometimes the physicians are reluctant to initiate such a therapy, and they are a bit hesitant. It may be because of the lack of awareness. They're not aware of the current guidelines. And sometimes perhaps they would also not bother why to start a new drug, and if they may have some complications and side effects. So they want to play safe. And that's why they have that inertia of starting a treatment. Now, there may be local restrictions in the hospital that they cannot use a new medication offhand, and there may be some problem with the supply. In addition, if there is no multidisciplinary team working in a hospital or in a clinical setting, then using such a medication, again, may become very difficult. Affordability is an issue, and it is a real issue because some of these medicines are really costly. Just to give you an example, the GLP-1 agonists, they cost on an average $50 to $100 per month supply. But whereas the SGLT2 inhibitors, they cost at least 10 times more. They are about $500 per month. So these are costly medicines. And of course, the affordability comes into the equation. And this may be one of the reasons that these medicines may not be used by some physicians or in some part of the world. In addition, it is very important whenever we initiate some newer drugs, not only for diabetes, any drug which we use, we must discuss, we must educate our patients so that their confidence is built and they adhere to the medication that are being prescribed. I'll come back to patient education again at the end of my talk because this is an important issue that we must tackle, and this is an important point to take from this talk. Now, we all know that patients who have got diabetes are certainly at risk of higher cardiovascular mortality compared to patients who do not have diabetes. And if you have more risk factors on top of diabetes, then your risk of dying of cardiovascular mortality increases several folds. So diabetes does increase your risk of heart disease by 2 to 3 times. Diabetes also increases your risk of dying by at least 60%. Now, when we use some of the newer anti-diabetic drugs, they come with some benefits, and these benefits are particularly for the heart, for your cardiovascular system. And this is just it summarizes on the screen. There are some metabolic effects and there are some non-metabolic effects. And with those, they have got a positive outcome for the cardiovascular trials. Now, as you all know, there were anti-diabetic drugs that have been, that came into the market, and very soon they were taken away because of the FDA put a requirement that these new drugs, particularly for the diabetes, they must show not only a means to improve the glycemic control, but these drugs must go under some kind of trial. And these are the safety trials that I'm talking about, that they must ensure that these drugs are safe, because it has happened that some of the medication, they have increased mortality, they have increased heart failure, and have caused other complications through using some trials. And therefore, FDA has become very strict now since 2008 onwards, that all the medication, new anti-diabetic drugs, must prove cardiovascular safety before it is can be used on the patients. Now, some of the medications, as you can see here, metformin has got a outcome which is a little bit doubtful as far as the cardiovascular outcome is concerned, but mainly it is the GLP-1 agonists and the SGLT2 inhibitors that have shown to reduce the cardiovascular disease risk. Now, over the number of years, in the last few years at least, a lot of trials have taken place with DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 agonists primarily. And these all are cardiovascular outcome trials that you can see here. And this again summarizes the major adverse cardiac event, all-cause death, and hospitalization for heart failure for all these medications. I don't want you to look into these details, but I'm just going to show you on the slide that this is what the drugs, they need to prove, that they must prove the cardiovascular safety for these new anti-diabetic drugs. I'm just going to discuss very few studies and very, very briefly. My intention is not to go into the depth of these cardiovascular outcome trials, but just to give you a flavor as to what these trials were and what the evidence was from using these medications as far as the cardiovascular outcome is concerned. So first study is the CANVAS study that used SGLT2 inhibitor and that used canagliflozin, and it used majority of the patients, 60% of the patient were diabetic who had established cardiovascular disease, meaning that they already had heart attack, angina, or stroke in the past, and 40% of them had risk of developing a cardiovascular disease. That means these were the primary risk group. And this was the way the study was designed. These patients were randomized. There was a renal arm, there's CANVAS-R and CANVAS, and they were put together into CANVAS program, 10,000 patients, either to receive placebo in one arm and in the other arm to receive canagliflozin. And coming straight to the result, primary MACE outcome, it did not show, it showed only modest statistical significance for superiority in favor of canagliflozin, but it showed highly statistically significant figures in favor of canagliflozin over placebo in terms of reducing the primary MACE, which was a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. Now coming to the next study, this is EMPA-REG outcome trial. Some of you may have heard about this. Now this one used empagliflozin, another SGLT2 inhibitor, and compared with placebo. Empagliflozin here was used in 10 milligrams and 25 milligrams against placebo. 11,000 patients were screened, randomized 7,000 patients into two arms. In fact, sorry, three arms, placebo, empagliflozin 10 milligrams, empagliflozin 25 milligrams. And coming again to the result, you see there was a benefit in terms of 3-point MACE in favor of empagliflozin compared to placebo. And the remarkable benefit was seen as far as the cardiovascular death is concerned. Look at the p-value less than 0.001, so highly statistical significant for the reduction of cardiovascular death. There was some increase in the non-fatal stroke, which I can discuss if somebody has got a question on this. I'm not going to go into detail, but there was a reason why the non-fatal stroke was increased in these patients. Now, again, this summarizes the same issue. The finding from the Canvas and the EMPA-REG outcome trial, there was a reduction in cardiovascular death. There was a reduction in non-fatal stroke for the empagliflozin, not for the, for the canagliflozin, not in favor of the empagliflozin, and there was a reduction in the all-cause mortality. The last trial I want to briefly discuss is the DECLARE-TIMI-3. This was another SGLT2 inhibitor called dapagliflozin. And this used patients, primarily these were the patients who were at risk of coronary artery disease. 60% of the patients were in the primary risk group. That means 40% had an event, but majority did not have a cardiac event so far when they were enrolled for this study. They were type 2 diabetic, and these patients were followed up for 4.2 years. And the positive outcome, primary outcome they were looking at was 3-point MACE again, cardiovascular death, MI, and ischemic stroke. Now, coming to the result, MACE was, for superiority, did not show statistical significance, but for non-inferiority, it showed a statistical significance of p-value less than 0.001 in favor of dapagliflozin compared to placebo. With regards to the cardiovascular death and hospitalization due to heart failure, there was a significant statistical significant difference was seen in favor of dapagliflozin compared to placebo. Now, this is the last trial I want to show you using R2-gliflozin, one of the other SGLT2 inhibitor, compared to placebo. This is the VERTIS-CV trial. And once again, it showed that it showed a p-value which was statistically significant for non-inferiority in favor of R2-gliflozin, but did not show any superiority as far as reducing the primary outcome 3-point MACE was concerned. Now, this is the composite MACE. Now, I'm switching gears to using the studies that have been done on the DPP-4 inhibitor, mainly sitagliptin, saxagliptin, allogliptin, and then the GLP-1 agonist, as you can see, liraglutide, semaglutide, exenatide, and so on. So except for the saxagliptin, and then for the lisasenatide, so this is the DPP-4 inhibitor, saxagliptin, which went against the drug in the trial, and lisasenatide, one of the GLP agonists, that did not show any benefit. In fact, both these drugs actually showed harm and in fact, these are the drugs, they are no longer used. They have been taken off the market, and FDA has put a hold on the use of these medications. Now, another glance of which of these GLP-1 agonists are safe to use. And now the evidence comes again for these GLP-1 agonists, the exenatide, liraglutide, semaglutide, and dulaglutide, and so on. So except for the lisasenatide, based on these studies, as you can see on the top, all these drugs are cardiovascular safe, and they can safely be used by clinicians, and they can be used by endocrinologists, primary physicians, even cardiologists are using now these medications. Now, LEADER is the first trial that was done by using the liraglutide in showing the evidence as to it had a positive cardiovascular outcome trial. Sorry, had a positive cardiovascular outcome in type 2 diabetes mellitus. Now, this was the study design. Again, please do not go into the detail. That is not my primary focus or objective, but I'm just going to show the results that once again, it was the liraglutide that was the winner in, compared to placebo as far as the cardiovascular event is concerned. And this trial again shows the LEADER trial that liraglutide is entirely safe, cardiovascular safe to be used in diabetes patients. So some of you may have heard there's a newer GLP-1 agonist called semaglutide that is being used by diabetologists. And again, it has shown a safety for its use in cardiac patients. And as you can see here, with the SUSTAIN 6 trial design, it has shown that it reduces the non-fatal myocardial infarction, it reduces non-fatal stroke, and also it reduces death from cardiovascular causes, which is again, death from cardiovascular causes not very significant. As you can see here, the p-value is only 0.92, but the non-fatal MI and non-fatal stroke certainly are in favor of semaglutide compared to placebo. Now, another GLP-1 agonist, dulaglutide. Now, the REWIND trial shows a very similar finding that there is a cardiovascular benefit in favor of dulaglutide compared to placebo. So essentially what I've shown so far that we have to choose the medication that have got evidence, and I've shown you a number of trials till now, and that have shown a remarkable benefit with the use of these newer anti-diabetic drugs in favor of these drugs, these newer drugs, compared to the placebo. So now the physicians must be aware of these trials, they must be aware of these medications and how they not only are safe, but they are also cardioprotective for these diabetic patients. Now, I've not gone into a few trials which has also shown, some of the trials have also shown a benefit for not only diabetic, but also for non-diabetic patients. So that is another area which is an exciting area for all of us, that even as a non-diabetologist, we may be using these medications for a better cardiovascular outcome. So when you face a patient and you face a diabetic patient, then obviously you need to look at the risk profile, whether these patients have got underlying cardiovascular disease, whether these patients have got underlying chronic kidney disease. And then, as you can see, you can go this route, whether they have got predominantly atherosclerotic disease or predominantly they've got heart failure or CKD. And then you can choose these medications on your own. So the life has become a little bit easy for us, even for non-diabetologists. And I certainly use in my practice these medications for my cardiac patients, and I can initiate these anti-diabetic medications for them on my own. So coming to, so what is the solution? As I've told in the beginning, that some of these anti-diabetic drugs which have been in the market for a number of years now, they have got a lot of trials in the favor that they do reduce cardiovascular outcome, and despite that, these medicines are either not being used or they are being used very little, or sometimes they are even being misused. So first and foremost, that we physicians must be educated. We must know our guidelines, and we must know the current guidelines as to what the evidence is from these cardiovascular outcome trials that I've just discussed. So these guidelines, they should not only be known, then they should be brought into practice, and meaning thereby that the physician should be confident enough to prescribe these medications. So they should be keen to prescribe even as a non-diabetologist. And if they are initiated by a diabetologist, then they must be confident to modify the dose, up titrate the dose as per requirement. Now, it is very important that the pharmacy and therapeutic committee, they should play a vital role in introducing these medications that are evidence-based, that have proven a benefit as far as the cardiovascular benefits are concerned. These medicines should be brought or introduced into the hospitals, and the physician should be made known to about these medicines that they can use. These medicines should be subsidized as far as the cost is concerned, and therefore it can be widely used. It can be of benefit for patients who have got a problem with the affordability. And lastly, we need to educate our patients. So patient education or medication education is extremely, extremely important. Now imagine these medications are very costly, and obviously the pharmaceutical company, they spend millions and trillions of dollars in coming up with these molecules which are so beneficial for the patients that none of the patients who actually are eligible to use this medicine should be devoid of these medications. Now, ultimately, who are the end users? So the end users are our patients. So it is very important that the end users are made aware of these medicines. They must be told that these are the medicines that are going to not only help with your blood sugar, reduce your HbA1c, but they are also going to reduce the chances of you having a heart attack or a stroke in the future. And also, they're going to help you live longer. Of course, any new medication brings about an apprehension or fear in the mind of the patient. But as we physicians, we have got to take that responsibility to make them understand about the side effects if they have any concern. So these are the things that needs to be discussed in the first meeting with the patient, so that the patient, they become confident using these medicines. And once they gain confidence with these medicines, of course, this will improve the adherence of the use of medications. And once the adherence is improved, definitely this is going to improve the patient outcome, including the cardiovascular outcome. But lastly, what is going to be benefiting is the resources. So you will save resources, you will save human lives using these, just a simple technique of educating these patients very well when they are using these medications. So with that, I would like to end here, and thank you very much for your patient listening. If you have any questions,